This conference will now be recorded.
Okay, so finishing off where so starting from where we finished off last time, we were talking about acute pancreatitis last time, and if you remember, when we talked about acute pancreatitis, we had finished with the management of the patient in the first week or in the early stages of presentation, the usual disclosures and acknowledgements. So this is now a continuation. We talk about the post first week management. And when we talk about the post first week management, we are basically looking at managing the complications and managing them, right? So, first, let's go back to the original overview that we gave to you in the first lecture. If you look at this overview, this was the part that we covered, the early 1 to 2 weeks when the patient usually presents with general symptoms. Now, at that time, we're not worried about the local presentation of this patient for the simple reason that the local presentation do not make a difference at that point of time. They are not severe enough, they do not develop enough to present any kind of clinical symptomatology. So in the initial presentation, that's why if you remember the Atlanta classification we talked about last time, we said that management of acute pancreatitis can safely be divided into two groups. First is the early stage, and the second part is the late stage, or the post-early stage. You can call it post-early stage. So here now we're going to talk about the post-early stage management of acute pancreatitis. Now, this is enclosed in the red. So you have late after 2 weeks and also the fluid collections in the early stages. This part is also common to both early and late, depending upon the time of presentation. So if you have less than 4 weeks of presentation of any fluid collection without necrosis, with necrosis, last time I think we specified this acute peripancreatic fluid collection, APFC, you can have a pseudopancreatic cyst, or if you have necrosis in this fluid, then you'll call it acute pancreatic necrosis, and late presentation with necrosis would be a ward of necrosis. Okay. Now, what are the guidelines? If post first week and into the second week, if you find that the recovery is not as expected, number one. Number two, the pain persists or increases. Number three, the fever appears or persists. Appears for the first time or persists right from the first week itself. Or signs of sepsis are persisting or appear for the first time, and or organ failure not responding. Now, if any of these, if you find any of these in your patient, then you should look out for the local continuation or aggravation of pathology, that is the local pathology, with related local and general manifestations. And at that point of time, a CECT becomes mandatory. That is a contrast enhanced CT examination becomes mandatory. Right. Now, the complications, if you look at the complication of acute pancreatitis, they can safely be divided into the general complications and the local complications. Among the general complications, you got the multiple organ dysfunction syndrome or multiple organ failure, which can include the renal, the respiratory, the cardiovascular, the GI in the form of IAS. You can have a neurosurgical in the form of confusion and encephalopathy. You can have metabolic complications in the form of hypocalcemia, increased blood sugar, increased lipids, or you can have a disseminated intravascular coagulation syndrome. The local complications are by far more important in the post first week, and you can have the collections with or without infection. We just not talked about that. A reference given here also. Others, apart from these local collections, you can have a pancreatic ascites, you can have a pancreatic pleural collection, you can have a loculated or it can be aspirable. You can have a vascular complication in the form of aneurysm of hemorrhage or portal and splenic vein thrombosis. So these are the complications that we are basically looking at. So up to 4 weeks post onset, the local complications are basically those where a management is not really required. Why? Because at that point of time, a wall has still not formed. So, see, before 4 weeks, the collection is without any fibrous wall, and that's why you have to wait and watch. You have to bide your time and wait for the eventuality in that collection. So, if you have an acute peripancreatic fluid collection, which occurs in almost 30 to 60% patients of acute pancreatitis, depending upon the severity, and if it is less than 4 weeks, and it is sterile and asymptomatic, do not do anything. It is self-resoluting. In a very small percentage of cases, if within the first 4 weeks, if this collection becomes symptomatic or is huge or infected in any of these scenarios, then you can go in and do a percutaneous aspiration, which could be a CT ultrasound guided, or you can do a transgastric aspiration ultrasound guided, that is a endoscopic ultrasound guided, right? So remember, first, before first 4 weeks, because there's no fibrous wall, you have to tread very, very cautiously, and you have to wait and watch unless and until there is something which is impending, causing severe symptoms to the patient. Do not do anything. If it is, then do the minimum possible, and that is just aspiration or transgastric aspiration through the cyst, either percutaneous or transgastric aspiration, right? If on the other hand, in the first 4 weeks, you have acute necrotic collection or acute pancreatic necrosis, the incidence is almost 20% with acute pancreatitis. See, the incidence of acute peripancreatic fluid collection is almost 30 to 60%. And here, the incidence is almost 20% patients with acute pancreatitis. And if you look at the incidence in those patients who ultimately die of acute pancreatitis and autopsy is done, it's almost 80%. So an acute necrotic collection becomes a major problem in patients with acute pancreatitis. Again, up to within the first 4 weeks. Remember, we talk about before 4 weeks. Now, here the necrotic pancreatic tissue and the lysis of the peripancreatic fat is the content of that collection. And it is best diagnosed based on a peripancreatic, based on a contrast enhanced CT examination located intra or peripancreatic. So this necrosis can either be inside the pancreas or by the side of the pancreas. Okay. Now, a word of a very important diagnostic modality is a contrast enhanced CT examination. And a logical question is that the patient comes to you today with acute pancreatitis. Do you immediately order a CT scan? Is it going to give you any beneficial information? No, it is not. The CT scan, whether it is a non-contrast NCCT or is a contrast enhanced CT examination, becomes informative only 72 hours down the line. Remember this. 72 hours after the onset of the attack becomes informative. You can do it within 24 hours, no problem with that, but it's not going to give you any relevant information. So relevant information as far as collection is concerned, as far as necrosis is concerned, these are the relevant investigations that really want to find out what is happening locally, will only be available 72 hours down the line after the onset of acute pancreatitis, right? Now, the treatment of this, which is within the first 4 weeks, remember, no intervention required. Intervene only if there is persistent pain, biliary enteric obstruction, failure to improve clinically. Delay intervention as much as possible to allow walling off. So, what is the message that we get from this? The message that we get from this is that within the first 4 weeks, any collection in and around the pancreas, whether it is a fluid collection or it is a necrotic collection, should best be left alone, not tampered with, unless and until it becomes a dire emergency to do so, depending upon whether it has become symptomatic or it has become infected. These are the only scenarios where you'd like to touch these collections within the first 4 weeks, whether it is with necrosis or without necrosis. Okay. Now, if there is infection in this necrotic collection, if it's infected necrosis, the mortality shoots up to 50%. And that is the time when you do require some kind of intervention. The rate of infection is directly proportional to the amount of necrosis. That means the more the necrosis, the more the infection. So if you have a 30% necrosis or one-third necrosis, the infection rate is 22%, and you go 70%, that's two-thirds of the pancreas undergo necrosis, the infection becomes 50%. Right? What causes this infection? The bacteria which have been translocated from inside the intestinal lumen. That means E. coli, Klebsiella, Pseudomonas, and Enterococci. And how does it present? All-round deterioration after 1 week. So post 1 week, remember I told you the guidelines. Post 1 week, if you find that clinically the patient is not responding, there's prolonged fever, sepsis, SIRS, organ failure, biochemical parameters are showing a persistent increased polymorphonuclear leukocytosis. Radiologically, you find air trapped within the necrosis on CCT, or you do a needle aspiration and you aspirate pus. These are the indications where you have to go in for intervention. And what do you do? How do you intervene in these acute necrotic collection which has become infected? Or in those sterile where there is symptomatology that forms a very small group of sterile collection. So either you have an option of a guided aspiration, you do guided aspiration, guided basically ultrasound or CT guided, followed by a wide bore tube drainage. So you aspirate and put in a wide bore so it keeps draining. Or you can do a necrosectomy. Necrosectomy basically means remove the necrotic part, either by an open method, open necrosectomy, or a laparoscopic necrosectomy. So remember, infected acute necrosis, acute pancreatic necrosis within first 4 weeks requires intervention only if there is infection, and then that becomes a major problem. Why? See the operative mortality, 30%. So you got a number of options to remove that infected necrosis. Because if it is sterile, do not touch the necrosis. If it is infected, remove the necrosis. You may have to remove it. And the options available are either an open necrosectomy, either or a minimal invasive approach, either as a step-up approach or an endoscopic approach. Or if else a pancreatic abscess has formed, then that also requires a treatment. So if you're doing open necrosectomy with operative mortality of almost 30%, the options are varied. Number one, either you can do a closed drainage, that means you open the abdomen, you do a removal, and then you put in a drain, that is closed drainage. Or you can do a closed continuous drain, that basically means you put in two tubes, through one you keep on infiltrating fluid and the other keeps on removing the fluid. I'll show you in a next slide. Or you can do an open packing. What does open packing mean? You've done a laparotomy, there's a large cavity, you pack it and leave the abdomen open, just apply 2 or 3 stitches so that you can go back in and do a re-laparotomy. And that is what is known as a closure and re-laparotomy, and removing that pack from that particular area. Or you can do an open retroperitoneal necrosectomy. So instead of opening the abdomen from the anterior part, you can go from the posterior, directly approach the pancreas and remove the necrotic part. In any scenario, whenever you're doing an open necrosectomy, the patient is so ill that the patient cannot take anything orally, and that's why a feeding jejunostomy is an option we should always be strongly considered. If you're going in for a minimal invasive approach to the necrotic collection, you have a step-up approach, which is the most common approach as of now. That is step-up basically means you do a percutaneous drainage, and then subsequently, once you've done the drainage percutaneously, that is followed by a minimal invasive video assisted retroperitoneal debridement for both non-infected and infected necrotizing collection inside the pancreatic tissue, right? So once you've done percutaneous drainage, then you go ahead and do a minimal invasive video assisted retroperitoneal debridement. Results are better than open necrosectomy, and that is why this is now preferred over the open necrosectomy. Or you can do an endoscopic approach where you drain everything inside the stomach. You put an endoscope, go through the posterior wall of the stomach, enter into the necrotic tissue and remove it. That is a transgastric endoscopic. Now, you need a wide area to do all these things, and that's why you have to dilate the tract with a balloon. So, it's the balloon dilatation of the tract is required before you can achieve a transgastric endoscopic necrosectomy. A large Mohs stent is then left in place, and this may or may not be combined with a tube which is draining percutaneously. So you've done everything endoscopically, put in a tube percutaneously so that that cavity is approachable at all times. So better results versus step-up approach of lower pancreatic fistula. So if you have a step-up approach, because remember, now you're opening it to the exterior, so the chance of having a pancreatic fistula is very high. If you're doing endoscopic approach, chance of having a pancreatic fistula is very low, and that's why endoscopic approach is the best approach among all the approaches. If you have a pancreatic abscess, pure collection of pus, then of course you have to go in and do a complete evacuation and removal. And a pancreatic abscess would form it under two scenarios. One, it could be an infected peripancreatic fluid collection (APFC), or a pseudopancreatic cyst, or an infected necrosis, right? This is what is known as the continuous. See, this was part which has undergone necrosectomy. You put in two tubes. Through one, you push in fluid. Through the other, you drain it. So this is continuous post-operative closed lavage. Why closed? Because I have closed the abdomen. So this is the closed lavage, which is now one of the methods of doing it open by the open way, right? Now see the lower part of the slide, post 4 weeks after onset. So now we understand that within 4 weeks, there is no fibrous wall, whether it's an acute peripancreatic fluid collection or there is a collection of necrotic tissue, which is known as the acute pancreatic necrosis. Before 4 weeks, that wall is not going to form. Subsequent to 4 weeks, it is going to form, and then it becomes what? Either a PP cyst or it becomes a wall of necrosis. So up to now, we have dealt with this APNC and we have dealt with APFC. That's the first 4 weeks. That is what we are just now talking about. Now let's talk about the late presentation post 4 weeks when it becomes a pseudopancreatic cyst and it becomes a wall of necrosis, right? Either PP cyst or wall of necrosis, depending upon if there is amount of necrotic tissue inside or not. Now, what is the cause of a pseudopancreatic cyst or a wall of necrosis? Now, post acute pancreatitis and in patients with chronic pancreatitis. In chronic pancreatitis, we'll talk about that when we talk about chronic pancreatitis, but just remember that these cysts are small and multiple. We'll finish it at this point. Let's talk about acute pancreatitis. Now, 5 to 15% patients of acute pancreatitis will ultimately land up with a pseudopancreatic cyst. Not a very large, but almost one fifth. See, 1/20th to 1/5, almost 1/5 of patients will be having an pseudopancreatic cyst. And if you look at the conversion rate of an acute pancreatic fluid collection into a pseudopancreatic cyst post 4 weeks, it is almost 25 to 50%. That means approximately half to one-fourth of these patients who have had an acute pancreatic fluid collection in the first 4 weeks will ultimately would go on to form a pseudopancreatic cyst, right? Now, in acute pancreatitis, it is always solitary. Multiple in only 17% patients, right? 20 to 29%, that means almost two-thirds would resolve spontaneously. Now, 20-29% is an average. It can vary from 8 to 70%, but you can just say that about one-third, half patients would resolve spontaneously. That means the pseudopancreatitis disappears. And how does it do so? It has a ductal drainage by an organ drainage or a peritoneal drainage. That means it has burst into a particular into the pancreatic duct and through the duct goes into the ampulla, or it has burst into an organ, like for example the stomach, or it has undergone a peritoneal dissemination. It has burst into the peritoneal cavity, or it could be because of extra peritoneal drainage, right? By definition, why do we call it a pseudopancreatic cyst? Because by definition, the wall has no epithelial lining, only fibrous capsule. Remember, this is very important when you want to differentiate it from a true cyst of the pancreas. Okay. Now, what could be the site? Where can you find the pseudopancreatic cyst? Anywhere down from thorax into the pelvis. Why? It starts here. See, the whole story starting here. There's the pancreas, the collection of the pancreas, and the lesser sac, the most common site of a pseudopancreatic cyst, right? Now, from here, it can track down anywhere. It can go through one of the apertures of the diaphragm and be found in the posterior mediastinum. It has also been mentioned in the neck also. Neck, remember, neck. And down, it can be found into the part of the transverse mesocolon. See the two leaves of the transverse mesocolon tracking out here. It can be found anywhere in the retroperitoneum, right up to the pelvis, right? So, but these are uncommon sites. The most common site, of course, is the lesser oment, is the lesser sac, the next in line, transmesocolon, or it could be intrapancreatic or the head of the pancreas. These are sites where you find pseudopancreatic cells. What is the pathophysiology? There has to be a disruption of the pancreatic duct due to either inflammation, pancreatitis, or trauma, or malignancy, followed by extravasation of pancreatic secretions. Now, two-thirds of these patients with pseudocysts would be showing a demonstrable collection. That means you can demonstrate, yes, I can see this collection. But one-third, no connection is visible. And what has happened? Probably that connection has been sealed off and it is no longer demonstrable. The natural cause, I said earlier, almost 50% spontaneous regression, especially if it is less than 4 centimeter size, no pancreatic duct blockage, and no duct communication, right? Clinical features would be near the tail or body. If it is found near tail or body, as is found in more than 50%, the patient presents with pain, early satiety, nausea, and weight loss, depending upon the size of the pancreatic cyst. Now, the clinical findings, we just not talked about that. So you have asymptomatic, the most common. Secondary infections, pancreatic abscess is another presentation. Otherwise, the symptoms relate to number one, compression, number two, thrombosis of major vessels, number three, pseudoaneurysm formation, and number four, rupture. If you look at the compression or obstruction of adjacent organs, it can compress the stomach, giving rise to pain, early satiety, vomiting, duodenal compression, upper GI obstruction, CVD, obstructive jaundice. Thrombosis, the superior mesenteric, portal vein, splenic vein, pseudoaneurysm. Remember last time we talked about elastase, dissolving the media, tunica media, giving rise to a pseudoaneurysm in the splenic. That is one of the vessels. The other adjacent vessel, gastroduodenal, and the superior inferior pancreaticoduodenal vessels could be the other sites, and intracystic hemorrhage ultimately may result in pseudoaneurysm. Rupture can occur in the petroleal cavity, giving rise to pancreatic ascites and peritoneal hemorrhage. The signs is very typical. A cystic epigastric lump with transmitted pulsations may move with the respiration, cannot be anything with a history of acute pancreatitis, cannot be anything apart from a pseudopancreatic cyst. That is sine qua non. That basically means a history of acute pancreatitis with a appearing cystic lump in the epigastrium, transmitted pulsations, may or may not be moving the respiration, cannot be anything apart from a pseudopancreatic cyst. Is that clear? You can have a more laterally placed lump if it is found in the body and tape. Right. So diagnosis, more importantly, a differential diagnosis from true pancreatic cyst is very, very important. But to diagnose a pseudopancreatic cyst or a wall of necrosis, you need an ultrasound. A transabdominal ultrasound gives very good results. You can do a contrast enhanced CT examination. You can do a MRCP, or you can do fine needle aspiration. Aspiration is required if you see lower down to differentiate it from a true pancreatic cyst. And why do you need to differentiate from a true pancreatic cyst? Because you cannot treat a true pancreatic cyst as pseudopancreatic cyst. Why? Because true pancreatic cyst in a large percentage of cases could be malignant. Right. So how do you differentiate? So first of all, the diagnosis based on these, or you just do a variant meal lateral view, and you can find that the stomach is slit-like, sticking to the anteabdominal wall, and behind that you have a large cavity-like presentation of barium meal with nothing but a huge pseudopancreatic cyst. If you look at the differentiation, you'll find a low carcinomagnetic antigen level in the collection of pseudopancreatic cyst. If it is more than 400 nanogram per ml, it is probably a malignant cyst. High amylase is a part of pseudopancreatic. It can also be found in malignancy. You can have an absent mucin in a pseudopancreatic. Mucin is not there. Mucin is present in malignancies. We'll talk about that when we talk about the malignancy of the pancreas. And cytology will show inflammatory cells. What could be the complication of pseudopancreatic cyst? Infection, pseudopancreatic abscess, systemic sepsis, adhesions with AIU. And why does adhesion develop? Because a bowel can easily go and stick to the inflamed pseudopancreatic cells, giving rise to kinking. And the most common part of the bowel which sticks is the proximal jejunum, sticks to the undersurface of the transverse mesocolon, especially in cysts which are lying in the transverse mesocolon. It can rupture into the bowel, lead to GI bleed or internal fistula, or it can rupture into the peritoneum, giving rise to peritonitis. Pressure on the common bile duct or bowel, and it can erode into a blood vessel, giving rise to hemorrhage into the cyst or into the peritoneum. So management plan for pancreatic cirrhosis, when would you intervene? If for the first time, if it is more than 6 centimeter in size, it has already been 12 weeks that has been present in that particular area, it is symptomatic or complicated, and you're doing a serial follow-up of a pseudopancreatic cyst. If there's increase in growth, then you have increase in size, then you have to go and intervene. Now, how do you manage a pseudopancreatic cyst is that when the patient comes to you the first time, you do ultrasound or a CT scan, and then call this patient regular intervals of let's say about 2 weeks, 15 days, and then do a repeat ultrasound or CT examination and compare the sizes. If you find that the serially you're finding an increasing in the size, increase in the size of the pseudopancreatic cyst, then you have to go in for early intervention. Or if you have a pseudocyst and a chronic pancreatitis. So these are the absolute indications for intervening in a pseudopancreatic cyst at the first time. And what is the plan before intervention? Remember, always exclude a neoplastic cyst. An optional maneuver could be you can perform a pancreaticography through a ERCP, and if there's a communication to the pancreatic duct, the management becomes that much easier. Identify and treat a pseudoaneurysm. Evaluate the presence of portal hypertension or gastric varices. Until you've done all these, please do not go ahead and manage a pseudopancreatic cyst. Once you do it, then you've got two options to manage the pseudopancreatic cyst or a wall of necrosis. One is internal drainage, that means you drain it internally, and number two is external drainage. Internal drainage, endoscopic drainage, or stenting through the ampulla, or you can go for laparoscopic open surgical drainage. External, ultrasound guided aspiration or tube drainage, that means external to the exterior, and open external drainage. But the preferred is always, as of today, endoscopic drainage, which can either be transmural, that basically means going through the posterior wall of the stomach, or it can go through the ampulla in the duodenum, and that will be known as transpapillary. So, endoscopic drainage transmural and endoscopic drainage transpapillary. Okay. Now, what is required? The prerequisites for doing a endoscopic drainage, that there should be less than 1 centimeter proximity to the stomach or duodenum in the head of the pancreas. If it is the head of the pancreas, it should be near the duodenum. If it is the stomach, if it is in the body, it should be near the stomach. Why? Because that close adhesion is required, because once you drain it, if there is no adhesion, it is going to leak into the peritoneal cavity, right, where you make an opening. So you have to make an opening in that particular area where there is an addition between the posterior stomach wall and the anterior wall of the pseudopancreatic cyst, right? So transpapillary drainage is possible in those PP cysts which are communicating with the duct. So you do nothing, you put in a stent in the duct, and because the cyst is communicating with the duct, it's going to drain through the stent and the cyst disappears, right? So this transpapillary drainage with stenting if there is associated stricture also. Now, the recurrence rate is less than 5%. So if it is less than, less than 1 centimeter proximity to the stomach, you do a transmural. If it is the head of the pancreas, or there is a communication with the major ductal system, you do a transpapillary. Surgical drainage can be open or laparoscopic, and what do? You communicate the cyst with either the posterior wall of the stomach, a cystogastrostomy, or you do a cystoginginostomy. That means you communicate the cyst to the proximal part of the jejunum with the roux and Y anastomosis. You can also do a percutaneous drainage. That means I'm not doing internal drainage. I'm not opening it, doing a surgical drainage. I'll just like to put in a tube, and that tube I can put in percutaneously. Either I drain it, aspirate it, or I can put in a tube through the transgastric cystogastrostomy. Right? Recurrence rate almost 15%, requires great expertise. Now, overall recurrence rate is about less than 5%. If you look at all these procedures together, is less than 5%, right? This is a diagrammatic representation of pseudocyst management. See, this is the posterior wall of the stomach, and there the cyst. So what do? You open up the posterior wall and you anastomose the posterior wall of the cyst, the anterior wall of the cyst to the posterior wall of the stomach. So that has been anastomosed. So now you have got an opening. This is how it looks like. See, posterior wall, anterior wall of the cyst, posterior wall of the stomach. So now what have you done? You've made an opening out here, and this opening, see what I was telling you, adhesion. If I do an opening here, it is very good. I do an opening here, see there is no adhesion. So what's going to happen? Intraperitoneal leakage is going to leak. So this is correctly placed, this stent is incorrectly placed. Is that clear? So you have to be very careful when you're doing a transgastric drainage. Now, other complications of acute pancreatitis, you can have pancreatic ascites, you can have pancreatic acuteness fistula, you can have vascular complications. We already talked about that in the form of pseudoaneurysm and thrombosis. Pseudoaneurysm, why? Because elastase damages the tunica media, most commonly splenic artery. It could also be because of other vessels, and usually in association with infected necrosis or pseudocyst. If there's spontaneous rupture, hemorrhage will occur intraperitoneal or inside the gut. Recurrent hemorrhage is again a feature. Diagnosis very easily done on a CT angio or an MRI angio, and the treatment is best done by endoscopic method or by endo method, and that is embolization. Surgery is not a good option for managing pseudoaneurysm. The best option is the minimal invasive way and doing embolization of the vessel. Thrombosis can occur in any of these vessels, and ultimately they present as what? As a portal hypertension with gastric varices. This patient can present with bleeding, and in these patients, you have to do a manage of portal hypertension either conservatively, or you can go ahead and do a splenectomy. If the patient has a pancreatic acuteness fistula, 4% after an acute episode, right? See, not a very low percentage. 40% in patients treated with necrosectomy. So if you do a necrosectomy, the chances of having a pancreatic fistula jumps almost 10 times. So in an untampered acute episode, less than 4%. In a tampered, that basically means surgically intervened patient of acute necrosis, you have a 40% incidence of pancreatic acuteness fistula. Management is very difficult. In a word, conservative is a very small word for it. This is not the time to discuss how to manage a pancreatic acuteness fistula. But remember, treating a pancreatic fistula, pancreatic acuteness fistula, the norm is cutaneously. If you have pancreatic ascites, as occurs, it's a generalized chronic ascites and usually occurs because of pancreatic duct disruption. Amylase-rich turbid collection will be found. What is required is a wide bore tube drainage with or without octreotide, with or without nasogastric aspiration, with or without ERCP, with or without stenting, depending upon the presentation and the cause of their pancreatic ascites. That's why all these options have been given, right? Now, if you look at the outcomes of acute pancreatitis, the overall mortality is 10 to 15%. Recurrent attacks of acute biliary pancreatitis is 30%. And that is why, if we go back to the previous lecture before this, remember, manage acute pancreatitis, if it is a mild attack, the laparoscopic cholecystectomy should be done at the same hospital admission. And here you have a reason why it should be done at the same hospital admission. Because if you send the patient back home, the chances are one-third of them are going to come back to you with a fresh attack of acute pancreatitis, which you don't really want, right? Now, coming to chronic pancreatitis, and if you look at chronic pancreatitis, the definition is very important. Look at these words: persistent, progressive, what inflammation, or what pancreatic parenchyma. What else is required for the definition? It is an irreversible destruction. If you remember the definition of acute pancreatitis, what did you say? Reversible inflammation, right? Reversible inflammation. Here it is irreversible destruction. And once something is destroyed, it has to be replaced by something. So here the pancreatic tissue goes away, it atrophies, and it's replaced by what? Fibrosis. So it's characterized by severe chronic pain. Later stages, in the initial stages, you start having insufficiency of both the components of the pancreas, that is exocrinal and the endocrinal insufficiencies, and frequently these patients of chronic pancreatitis would have recurrent attacks of acute pancreatitis intervening. Incidence is very, very variable. We don't have figures for general Indian population, but South India population, we have 100 to 200 per lakh of population, which is almost 10 times more, 10 to 20 times more as compared to the USA and Japan figures, which have got 2 to 10 cases per lakh population. And just to bring you up to date and to give you a proper perspective, chronic pancreatitis is a disease of southern India. It is very, very common in Kerala. The highest incidence anywhere in the world is found in Kerala of chronic pancreatitis. The male outnumber the females 4:1, and the mean age of onset is about 40 years, right? Now, what are the risk factors? When you talk about the risk factor of acute pancreatitis, the risk factor of chronic pancreatitis is slightly different. Some are common, like for example, alcohol makes up 60 to 70%, but only 5 to 10% of alcoholics develop CP. Both the figures are important. If you remember the figure of acute pancreatitis, we said about 40% of patients of acute pancreatitis would be having a history of alcohol abuse. Now here, only about 60 to 70% of patients would be having a history of alcohol intake. But out of all patients who are taking alcohol, only 10% of them maximally would develop chronic pancreatitis. 20-30% of patients would not be having any clear-cut cause, so you would labeling them idiopathic, which would including the tropical pancreatitis, which we just now said in Southeast Asia, South India, Kerala, and the remaining 10% of chronic pancreatitis would be having an identifiable cause, like for example, a disruption, a pancreatic stenosis. They could be having a hereditary, malnutrition, autoimmune, cystic fibrosis, and metabolic cause for their chronic pancreatitis. These could be in the remaining 10% of patients, right? Now, why does alcohol cause chronic pancreatitis? Number one, there's increased protein concentration. It goes and blocks the ductule. So if the ducts are blocked, what is going to happen? The SNR are gradually going into, they cannot secrete. So what happens? Autodigestion sets in. Because the secretion becomes pent up inside the SNI, and that ultimately digests the SNR cells, leading to autodigestion. Number two, the byproducts of alcohol metabolism, they cause fragility of the SNR cell organelle. Number three, there's an enhanced necrotizing factor or necrotizing factor upgradation, activation of the normally quiescent pancreatic stellate cells. Now, these are stellate cells which are commonly found at the base of the SNR cell. They normally quiet, but when they get stimulated, they lay down connective tissue. The second reason was smoking. The third is hypertriglyceridemia. And then, of course, autoimmune, we just now said here in 10% autoimmune. So, what are autoimmune? Male more than female, 80% of patients are more than 50 years, and you'll find evidence of other autoimmune diseases. You have bulky pancreas, distorted ductal system, and there are two types of autoimmune. One is IG4 type, more common, and type 2 is pancreatic specific disorder not related to IG4. Genetic mutations also play a role in chronic pancreatitis as also in acute pancreatitis. So here it is autosomal dominant presentation, 80% penetration. And what do you have? The important genes that are involved is the PRSS1 gene, which is nothing but the mutated cationic trypsinogen gene, also known as protease serine 1, PRSS1, found on chromosome 7. Why? It produces degradation resistant trypsin. So that trypsin is no longer being degraded, so it will keep on having its effect. Prolonged action of trypsin. Mutation in the second gene, that is the SPINK1. What happens with SPINK1? The normal role of SPINK1 basically it deactivates the prematurely activated trypsinogen. So if there's mutation, its function decreases. So the trypsinogen which has been activated is no longer being deactivated. So if it is not being deactivated, the action of trypsin keeps on increasing. And when does it occur? This mutation of SPINK in alcoholics, hereditary, and idiopathic pancreatitis. Then you can have a CFTF gene. This basically is the cystic fibrosis gene, transmembrane gene, and this decreases the bicarbonate secretion, volume of pancreatic juice. So if there's decrease in the alkaline part of the secretion and there's an increase in the enzyme concentration, that ultimately leads to what? Ductal damage. And then, of course, the last gene to be affected is the mutation in the human chymotrypsin C gene. So we are basically talking about four important genes which are mutated and found in patients with chronic pancreatitis. Pathological changes in chronic pancreatitis, what do you find? Number one, pancreas is enlarged, it's hard. The ducts will always be distorted, dilated, strictured, ectasia is there, occlusion with gelatinous protein material are all changes found at the ductal level. You will also find ductal stones, often multiple and very large, up to 200 milligrams. Remember, 200 milligrams is a very huge stone load on the pancreatic duct. Histologically, what do you find? You find changes both in the ductal epithelium and at the acina. At the ductal epithelium, what do you find? Metaplasia. At the acina, what do you find? The acina atrophy and lobular fibrosis. More than 90% of gland needs to be dysfunctional before the appearance of exocrine insufficiency. That is to say that in the early stages, the only presentation would be pain, no exocrinal, no endocrinal insufficiency. Until more than 90% of the gland has been rendered useless by fibrosis, only then you will start getting exocrinal insufficiency. Right? A word about tropical idiopathic chronic pancreatitis, that is basically ITCP. Why tropical idiopathic pancreatitis? Because this is a common scenario in the southern part of India. It's a juvenile form of chronic, calcific, non-alcoholic. All the three terms are very, very important. It has to be chronic, it has to be calcific, a lot of calcification, and no history of alcohol. Almost exclusively in developing countries of the tropical world, in India, in Kerala. The classical triad of TCP or tropical chronic pancreatitis includes number one, abdominal pain, number two, steatorrhea, and diabetes. Three important features to say that the patient has got chronic pancreatitis. This diabetes, when it is present, is a brittle diabetes, and then it is known as fibrocalculous pancreatic diabetes. Why fibrocalculous? Because the stones are present and fibrosis is present, right? And the diabetes, I said brittle. Why? It is severe, insulin dependent, but ketosis is rare. Trying to control the diabetes is very, very difficult. The other distinctive features of TCP include a very young age at onset. Remember, I told you average age was what? 40 years, right? Here it sets in at 20 years. Number two, presence of large intraductal calculi. Number three, very, very aggressive course of the disease. And number four, a high susceptibility of pancreatic cancer. These are the features which sets it apart from a routine chronic pancreatitis. In a routine chronic pancreatitis, you will not be having these features, or you have them in smaller measures as compared to a patient of a TCP or a tropical chronic pancreatitis. The etiology remains uncertain. Why does it develop and why only in Kerala? Number one, it could be genetic, SPINK1 gene mutation, or more important, probably environmental factors. And these environmental factors are dual. Number one, possible toxicity from consuming large amount of cassava, which is a tuber, which contains cyanogenic glycosides, and exposure to hydrocarbons from kerosene and like fuels, right? So these are probably the two reasons that they've zeroed on to as the causes of chronic pancreatitis, especially the tropical chronic pancreatitis. The presentation, the most important and the all pervasive is pain, primary and most significant. The site, if it is a pancreatic head chronic pancreatitis, then it's epigastric pain and right subcostal pain. If you have the involvement of the body and tail, the pain will be felt more on the left side, namely the back and the left hypochondrium, and you can have a referred pain to the left shoulder, known as the Eisenberg's sign or Eisenberg's phenomena, which we have alluded to a number of times in for the previous lecture. This is basically pain felt in the left shoulder in a patient chronic pancreatitis. Why this occurs in one of the later lectures, I'll tell you. Now, it is precipitated by oral intake. Nausea is positive. The pain is usually dull with frequent acute exacerbation. The intensity, duration, and frequency increase with time. That means if I start having a chronic pancreatitis today, my pain will be different from what I'll be having 1 year down the line. Then it will become more intense, it will remain for a longer period of time, and it will occur more frequently. Right? The quality of life, the QOL is quality of life, is affected in a major way. The intake decreases, the patient becomes very lean and thin, there's significant weight loss, frequent use of analgesic, and becomes the patient becomes dependent on narcotics, and interference with daily activity is the norm in patients having a long-standing chronic pancreatitis. Why does the patient have pain in the first place? Either because of ductal hypertension, that means there's increased tension in the duct, or there's a chronic pancreatic inflammation irritating the nerves inside the pancreas, or there's a progressive perineural disease, are all probable causes for the pain. As I said earlier, exocrine efficiency will occur only in 80 to 90% of patients with long-standing disease and only after 90% destruction of gland. And how does it manifest? Steatorrhea in 30% of patients, diarrhea, deficiency of fat-soluble vitamins in the form of bleeding, osteopenia, osteoporosis. Endocrinal insufficiency, on the other hand, the reports are very varied, can occur from 4 to 80% of patients, and some brittle diabetes. We already talked about what kind of diabetes it is. Jaundice could be found only in 5 to 10% of chronic pancreatitis patients, and that also in those patients who got a scarring of the terminal CVD. Duodenal obstruction may be found in those patients having a scarring of head, of the pancreas, upper GI bleed if there is portal vein or splenic vein thrombosis and portal hypertension, or you can have a pseudopancreatic cyst, smaller and multiple. So among all these, the first is pain. The second, exocrinal, endocrinal, and then these are presentations which are uncommon presentations, but nevertheless they are presentations of chronic pancreatitis. How do you diagnose pancreatitis? Chronic pancreatitis. One, you can do a pancreatic function test, and the best exocrinal function test is just measure the stool elastase level. Forget about the Lund test and the others which we mentioned just for the sake of mention that these are the tests which are done for exocrinal pancreas. They're more for the investigative in those patients where you're going in for some kind of a study. But as a routine clinical practice, Lund tests, etc., are not very informative. You just do a stool elastase level, normal about 200 microgram per gram of feces. Anything less than 100 microgram tells you there is a major exocrinal insufficiency. You can do a plain scanner of the abdomen. You will find calcification and stones along the duct. You can do ultrasound. It is not useful, so not indicated. So in the next patient chronic pancreatitis, please do not order an ultrasound. Instead, the gold standard should be carried out, and that is be resorted to. And what the gold standard? A CECT, that is basically a contrast enhanced CT examination with a sensitivity of almost 95% and specificity 85 to 100%. That's why it is considered the gold standard. And what is going to show you, what is the information is going to impart to you? Number one, gland fibrosis. Number two, gland calcification. Number three, ductal distortion and dilatation. See the figures 54%, 50%, 68%. And it can also show you complications like a stone formation, a pseudocyst formation, thrombosis of major vessels. It can also show you pseudoaneurysmal formation in the splenic artery or the duodenal artery. The next in line is the MRI or MRCP, which is again a better method to show the ductal configuration of the pancreas, and especially those where you're suspecting a very minor ductal alteration, you can combine MRCP with secretin, which shows ductal anatomy in very mild cases to be altered. ERCP initially was considered to be the gold standard of diagnosis, no longer so. ERCP is only required for showing the ductal anatomy and for therapeutics. So it's both diagnostic and therapeutic. You can do a endoscopic ultrasound, EUS, most accurate technique for early CPTZ. So you have chronic pancreatitis just developing, do a EUS. Ultimately, a histopathologic examination is mandatory in chronic pancreatitis, especially in those patients where you would like to differentiate from a pancreatic cancer. I would like to strike out my word mandatory. It is not mandatory, but it would be better if you have it, but it's not mandatory. Remember that. So, what is going to show you? Inflammation, atrophy, and fibrosis are the gold standard of chronic pancreatitis. But ultimately, the bottom line is that whenever you're trying to diagnose chronic pancreatitis, the bottom line is you have to differentiate it from pancreatic cancer. Why? Because the clinical, the histological, and the diagnostic imaging methods are so similar. The results are so similar among the two that it becomes very, very difficult to differentiate in borderline cases. Full blown pancreatic cancer, nothing to differentiate. Yes, this is pancreatic cancer. But if you have borderline cases, it's very, very difficult, right? So, what is the treatment of chronic pancreatitis? The conservative is the mainstay of therapy. And what is the conservative therapy? Number one, treat the cause. Treat the cause. And what is the cause? If you find alcohol, tobacco, high lipids, you can probably stop them and you can probably retard the progression of the disease. Probably, I say it's not a must. But the most important part of management is palliation of the symptom. And which symptom is the most important? Remember, I told you 90% of these patients we're presenting with chronic pain. So treat the pain. And how do you treat the pain? Initially with drugs. And drugs in the form of graded progression for increasing and persistent pain. You proceed from non-steroidal anti-inflammatory to steroidal to narcotics. So you have a long-standing narcotic and tricyclic antidepressants may also be required. Gabapentin is also given and serotonin reuptake inhibitors also required in a number of patients, right? If not responding, then you resort to a pain management expert, and there you got a number of options. One, it could be a guided celiac ganglion neurolysis that you block the celiac ganglion, so you're cutting on the sympathetic fibers coming to the pancreas, and those sympathetic fibers are carrying pain for you. Or you can go in for a surgical procedure, and these surgical procedure, if you find that the duct is involved, so you can go in for drainage of a small duct, you can go in for drainage of dilated duct, you can go in for dissective procedure, or you can take resort to procedures largely determined by cause of pain, that ductal block or no block. So basically, what you're looking at when you're going in for surgery of chronic pancreatitis is whether the duct is blocked or not blocked. That is the point of major diagnosis. So you have to diagnose whether this patient chronic pancreatitis has got a ductal blockage or has not got ductal blockage. So that is treatment of the pain. Now, what about exocrine insufficiency? Treating exocrine insufficiency has to be conservative. So you're just going to replace the pancreatic enzyme, and a rough measure you can give exogenous 20,000 to 50,000 units of lipase per meal. And why lipase? Because mainly lipase is required among all the pancreatic enzymes. Lipase is the most important component. So to avoid malabsorption, lipase is required, and the dose of lipase is 20,000 to 50,000 per meal in an adult. Now, it has to be combined with PPI. Why? Because exogenous lipase gets inactivated by the stomach acid. So if you're giving a PPI, that's going to decrease the stomach acid. Because if you don't give a PPI, a plain and simple lipase, only 8 to 15% reaches the duodenum. That means 1/10 of your giving lipase has reached this of the duodenum. So basically, if this is required per meal, then it has to be substantially increased. So in patients with chronic pancreatitis, because there is also decrease in the bicarbonate secretion, and that is why again there will be increased acid content. So together in a patient with chronic pancreatitis, there is very high chance of whatever you're giving as a lipase, external lipase, is going to get inactivated. That's why PPI is required for acid suppression, and that will increase the effect of pancreatic enzyme. Diet modification is very important. It has to be low fat, and low fat, especially medium chain triglycerides. Why medium chain triglycerides? Because absorbed directly into the small intestine without need for digestion. Now, the problem with chronic pancreatitis is what? Lipase does not digest the fat. fat does not get absorbed, so you go in for a negative balance, right? Weight. But if your fat does not require digestion, gets absorbed by itself, then obviously it doesn't require the pancreatic lipase. And that happens only if your diet is rich in medium chain triglycerides. High protein and high carbohydrate also required. So if you look at an overall treatment of exocrine insufficiency, you'll require PPI, low fat diet plus lipase in a dose of 20 to 50,000. You like to give this patient fat soluble vitamin B12. You like to give this patient macronutrient therapy in the form of methionine, vitamin C, selenium. Control the steatoria, often not very easy to do so, and steroids are indicated only if it is autoimmune pancreatitis. Endoscopic management, no level 1 evidence. So initially, the treatment in every patient with chronic pancreatitis was endoscopic, ERCP and sphincterotomy. As of today, Love and Bailey does say that that should be the treatment of choice, but the rest of the textbooks of surgery say that there's no longer the gold standard, and that is the consensus of opinion. There's no level 1 evidence for symptomatic patients, especially pain. Yes, you can go for endoscopic management and you do endoscopic sphincterotomy or major papillae, or you can do a sphincterotomy or minor papillae in patients of pancreatic divisum, right? That would relieve what? The CVD pressure and the pancreatic pressure. Endoscopic dilatation and stenting in strictures always rule out pancreatic cancer before you're going in for dilatation and stenting. Please do not treat a borderline case of pancreatic cancer by dilatation and stenting. So you have to be very, very careful. I remember I told you borderline cases, the bottom line is you have to differentiate between chronic pancreatitis and pancreatic cancer. Pancreatic stone removal can be done either by fragmenting it or a complete removal as such. Neuroablative management may be required. I told you that you can do a celiac plexus block or neurolysis. We said that endoscopically. But if that does not suffice, then you can also go in for a trans thoraco-abdominal splanchnicectomy. That means the three splanchnic nerves. You can go in for doing excision or transection of these nerves, giving 50% long-term and transient relief in 70% of patients. So the surgical options in chronic pancreatitis, the indication says that despite all the conservative method, your pain is not responding, intractable pain. The CVD or the pancreatic duct obstruction is there, duodenal obstruction is there, PP cyst has formed, pseudoaneurysm is there, and a differentiation from carcinoma pancreas is unclear. So what is the anatomical basis of surgical option? I told you ductal dilatation or no dilatation. So if you have less than 7 millimeter duct, that means there is no ductal blockage or no major ductal dilatation. What do you do? Resectional procedures. If the duct is more than 7 millimeter dilated, you go in for decompressive procedure. Very, very simple principle. More than 7 millimeter pancreatic duct, decompressive. Less than 7 millimeter diameter pancreatic duct, resection. Right? Now, what is the procedure? So, we have pancreatic duct dilatation secondary to stones, multiple strictures, whatever the reason. And how do you diagnose it? You can find a chain of lake appearance on pancreaticography. That is very, very clearly seen. And if you find that evidence that there are a number of strictures, you find the chain of lake appearance, then you have to go in for, I just now told you, dilatation means decompression. So how do you do a decompression? By a pancreaticojejunostomy. And that pancreaticojejunostomy can be done by two methods, a modified Cousteau's. Even if you don't know the details, it is all right. But just remember, a modified Cousteau's or a phrase procedure are the two options available. In one, you're doing lateral or side-to-side pancreaticojejunostomy. I'll just show you a figure. Gives you almost 70 to 90% pain relief. See, very good pain relief figures. Or you can do a Frey procedure, which is nothing but local resection and longitudinal pancreatic jejunostomy. Right? See here in modified Cousteau, is there any resection? No. Frey's resection, yes. So this is a combined resective plus decompressive. In Frey's procedure, you're removing all a part of the head of the pancreas, and then the duct of Santorni Varsanga excised, and the uncinate duct is excised, and they, because you're removing that damaged part, so the cause of pain from pancreatitis is removed, so painful inflammation decreases, ductal hypertension disappears, right? Pancreatic duct dilatation secondary to a single stricture. So this is multiple strictures. If you have one single stricture, it is much more easy to manage. And how can you do that? Just proximal to the papillae, do a pancreatic stricture of the body or the tail, you find there's stricture in the body or tail, you have to do a distal pancreatectomy, right? So this is what a Pusto's procedure looks like. See, this duct has been opened up. See the chain of lake appearance? Chain of lake appearance? That is the duct, dilated places. So you've opened it up. Open it up. You're not excise anything. You open it up. And what do you do after opening? You brought a jejunal loop and you anastomose. This is how you do it. See, this is the anastomosis. So now where is the duct draining? Does it require the ampulla? No. All the narrowed parts have been opened up. So in totality, it's going to drain into the jejunum. So it is a pancreatic or jejunostomy. That's the Pusto's procedure for you, right? Now, there's a phrase procedure. Phrase procedure, I told you what? Excision plus drainage. So what are you excising? See, coring out of the pancreas. All this is going to be removed. So I'm removing all of this. This is basically before. Then when I've done the surgery, during surgery, and after surgery, everything has been removed. So what is remaining behind? A thin rim of pancreas. Now I'm going to do an anastomosis of the jejunum with the pancreas. So what is different between phrase and Pusto's is the excision or non-excision. So if we look at the third presentation of chronic pancreatitis, and that is focal mass without ductal dilatation. So remember I told you ductal dilatation. Ductal dilatation, single stricture, multiple stricture. So you can do a Pusto's, you can do a phrase. Now you've got no duct dilatation, but you got a focal mass. Now that mass has to be resected. Why? Because you can never be sure that you're not dealing with carcinoma pancreas. So focal mass without ductal dilatation, it has to be resection. But if you have no ductal dilatation, but instead of focal mass, you got a diffuse glandular involvement. Diffuse glandular involvement. Then again, resective procedures come to fore, and these resective procedures are either a distal pancreatectomy, that means the tail and body, or you can do a proximal, which is a Whipple's pancreatectomy, or because this has got a very high morbidity, you can do a duodenal preserving pancreatic head resection, DPPHR or Burger's procedure, or you can do a modified Whipple's. Just remember these procedures. Do not go into the detail. That's not for the MBBS level to know what these procedures are, but you should know what is basically being done. Because remember, in Whipple's, what are you removing? You're removing the whole of the pancreas, head of the pancreas. You're removing the whole of the duodenum. You're removing the gastric antrum, right? So what are you left behind? You left behind a hanging CBD, loosely hanging CBD. Why? Because you transected it. You have a distal end of the stomach open to the exterior, and because you remove the duodenal C, the jejunum is open, and the pancreas is open. So now you got four openings. The CBD is not draining anywhere. The stomach is not draining anywhere. The pancreas is not draining anywhere. The jejunum is not draining anywhere. So you have to do a whole lot of anastomosis. So you have to connect the CBD somewhere. You have to connect the stomach somewhere. You have to connect the pancreas somewhere. You have to connect the jejunum somewhere. So it involves almost four anastomosis. And that is why it has got a very, very high morbidity. And that is the reason why modified Whipple's is now being done. And in modified Whipple's, the modification is that please do not cut the pylorus of the stomach. Why? Because the pyloric sphincter is an important part of the stomach, and if you preserve the pylorus, then that becomes an important part of modification. That's why it's also known as pylorus preserving pancreatic duodenectomy, right? The other is that you do duodenal preserving, that instead not only the pylorus, you also preserve the duodenum. Now that is only possible if you're doing it in chronic pancreatitis. You leave a thin rim of pancreas along with the duodenum. And remember these resective procedures where there's no ductal involvement and diffuse glandular involvement, again the pain relief is 70 to 90%, which is very, very high pain relief, right? But if instead of doing a distal or Whipple's, which are both partial, because in one it is a distal partial, in the other it is a proximal partial, there may be an indication where the whole duodenum is involved and you may require a total pancreatectomy. All of the pancreas involved total pancreatectomy. But total pancreatectomy, remember, has got a very high morbidity, almost 40%, and mostly because the insulin becomes very, very brittle, very, very difficult to control the severity of hyper and hypoglycemia, both. It's very, very uncontrollable. And that is the reason why, if you're doing a total pancreatectomy, islet transplantation is now recommended with varied results. It's not a very easy procedure technically. Getting islets is difficult, and it has become varied results. Almost 30 to 50% of patients do become insulin independent. That's a very good figure. The rest are the partially or totally insulin dependent. This is what duodenal preserving DPP-HR in chronic pancreatitis Burger's procedure, just to show you how it is done. Basically, that will give you a better impression what is being done. So what you have done is you left the rim of pancreas. Now remember, I told you if you remove the whole head of pancreas, because the blood supply to the pancreas and duodenum is common, what's going to happen out here? You'll have to remove the duodenum. So if you leave a rim of the pancreas behind of the head of pancreas, you will not touching the pancreatic or duodenal arteries, right? The anterior and the posterior. So the duodenum does not undergo ischemia. The CBD is not touched. So what are you doing? You're just removing part of the pancreas in between the two. So this anastomosis is not required. This anastomosis is not required. This anastomosis is not required. What is required? Only one single anastomosis. Only one single anastomosis. That is the advantage of the duodenum preserving pancreatic head resection instead of the Whipple's where anastomosis here, anastomosis here, anastomosis here, anastomosis here, 4 anastomosis required. Here you just require one single anastomosis, right? So if you look at the comparative evidence-based data among the resective procedures between Frey and Berger and the standard pancreatic duodenectomy or pylorus preserving pancreatic Frey and Berger are much better as far as the incidence of diabetes is concerned. Pain relief is almost equal, very less operative mortality and morbidity, less length of hospital stay, more weight gain, nutrition, and better quality of life. So, on all counts, if you're doing a Whipple's or a pylorus preserving Whipple's, you will be having inferior results as far as the morbidity and ultimate results are concerned, as compared if you're doing a modified Whipple's in the form of either a Frey's or a Berger's procedure. In either of these, you'll be having much better results. But remember, a pancreatic duodenectomy or a pylorus preserving pancreatic would have to be done per force if you're suspecting malignancy. If it is chronic pancreatitis, you can get away without doing a Whipple. But if it is a carcinoma, then you have to go in for pancreatectomy or a PPD. So, if you have biliary stricture in these patients, that is beyond the pancreatic duct. If you got biliary stricture, that will, I told you these are presentations of chronic pancreatitis. So, if you have biliary stricture, terminal intrapancreatic part seen on ERCP, MRCP, just do nothing, do a ERCP, stent it. Or if you find the stenting does not solve their problem, then do a Roux-en-Y anastomosis of the CBD, either CBD or you go and do a porta. So you can do a hepatocystectomy if you are suspecting malignancy, then pancreatic duodenectomy has to be done. If the patient presents with duodenal stenosis, as in 1.2% patients, then do the first differentiate from other causes of gastric outflow obstruction and then do a gastrogenostomy. If the patient has got PP cyst in a chronic pancreatitis, found in 30 to 40% of patients, more frequently multiple, and only 10% are going to regress, but the treatment has to be as in a patient of acute pancreatitis. Prognosis, significant social and professional decline. It may burn out by itself, the pain disappears, but significant exocrine and significant endocrinal compromise results. So what does burning out of chronic pancreatitis mean? Basically means that the pain has disappeared, but there's significant exocrinal and significant endocrinal compromise. And a part which is very important is that chronic pancreatitis will proceed to malignancy in 5% of patients, and that also after 20 years. So that is a very real problem of chronic pancreatitis, an eventuality of malignancy after 20 years in 5% of patients, and that has to be kept in mind when you're dealing with chronic pancreatitis. I think that's all for today. We have finished with chronic pancreatitis. Next time we're going to talk about pancreatic malignancies. Thank you for your time. If you have any questions, you can always get back to me. Thank you.